CataractCoach.com. A surgeon learns flip and chop. It's a beautiful technique of flip and chop, including the best advice. We have an anonymous surgeon from Australia who sent the video in and making the incision here for the case. And of course, the most important thing in flip and chop is you got to be able to flip the lens and then chop it. So flipping it means I'm getting it out of the capsular bag. So you can't have a baby rhexis here. You really want a 5, maybe 5.5 millimeter capsular rhexis. That is really important. So do not make a baby rhexis. Now, it also depends on the density of the nucleus. A very soft nucleus, 1 or 2 plus NS, can come out very easily through a 4.5 to 5 millimeter rhexis. If it's a denser nucleus, 4 plus NS, you really need that 5.5 millimeter rhexis to get it out. So use my style of forceps marked off, and you can mark your own forceps, by the way. You don't have to buy anything fancy. Just use a disposable steel keratome and scratch in some marks at 5 millimeters from the tip, and then, of course, throw away that now damaged keratome. But here's the thing, hydrodissection, you got to get this lens out of the bag, so I like that tapping motion. And the key for me here is not force. It's slow and steady and continual. So even after I see the first wave going across, I don't stop. I continue to inject slowly and surely with low pressure and low speed. Not about speed. There's a little hydrodelineation that may help a little bit too. A little bit more, there it comes, and there it's up. You can see the delineation mark as well, getting that nucleus on its side. A little more viscoelastic to coat the endothelium. Look at that pre-placement of the chopper, smart move, I'll take that. Oh, a little more viscoelastic. Or perhaps that was more viscoelastic behind the nucleus as well. Here's the phaco probe going in and the chopper, getting that chopper in sufficiently deep. And look at that, you did it, beautiful job. Now that first piece has been chopped off and it can be emulsified pretty easily. And again, our goal is to stay away from the endothelium. We want to stay more so at the iris plane. And so it's going to require a few more chops. We're obviously showing you the video at 2 times normal speed, so that's why things are moving quickly here. And we want to get the point across to you in just 5 minutes, right? That's our favorite. 5-minute videos is what you guys like. So now rotating the nucleus around a little bit more. Now it's fallen back in the bag, but that's okay because now it's a lot smaller. So now you can bring it back up to the iris plane and then you can chop a piece off of it. So this surgeon here is doing a really nice job. Very nice technique. Eye staying in primary. Good draping, by the way. Looking at that as well. And now about half the nucleus is out. Here's the remaining half. It comes down pretty easy. That's a really nice technique. And the way this was done, that was beautifully performed. The patient's going to have an absolutely clear cornea the next day. So flip and chop, if you want to learn this, let's choose first a good patient. Make sure the patient has an average size eye or big eye, so IOL power of 20 diopters or so or less. Don't do it on an eye that needs a 28 diopter lens. It's a small, tiny eye, right? Second thing, make sure you get a sufficiently large capsular rhexis. Number 3, take your time, get good hydrodissection, hydrodelineation if you need to, and slowly but surely that nucleus will come up out of the capsular bag. And it may take quite a bit of fluid going behind there, multiple waves. Once that is up, I like the technique shown here where extra viscoelastic went in front of the lens to protect the endothelium and also behind the cataract to make sure it doesn't fall back in the bag. And then placing the chopper in the correct position and then phaco probe and the rest is easy. Here at the end of the case, you can see the IOL is in the capsular bag. Viscoelastic being removed with some bimanual IA, and that looks just about like a 5.5 millimeter rhexis. Beautifully done case. So again, flip and chop. If you're in a situation like this Australian surgeon and me in California where you have a lot of patients who have, 2 to 3 plus nuclear sclerosis as the main presenting level of cataract, this is a very efficient and very useful technique that really has a high margin of safety for your patients and it can produce really beautiful results, clear corneas the next day, and make surgery very efficient. And look at that, he's got a toric lens in there too, or she has a toric lens, lining that up with the correct meridian and finishing up this case. So beautifully done. Keep those pros in mind. Yes, you can definitely learn phaco, flip, and chop. Not that hard to do. You got to be just diligent. And remember the key points again. Good sized rhexis, no baby rhexis, at least 5 millimeters, maybe a little bigger if it's a denser nucleus. Number 2, slow and continuous hydrodissection, maybe a little hydrodelineation, get that nucleus up out of the capsular bag. And number 3, a little small aliquot of viscoelastic to protect the endothelium, and optionally another small aliquot going behind the cataract to make sure it doesn't fall back in the capsular bag. And then, hey, just take care of the case. Thanks for watching.